It's live. It's live.
Kovil sir is there. Hello, is it started?
Yes, yes. Can you start on your camera?
I think Kovil sir is not there.
Start and then I'm backstage.
Good
Okay.
evening, all the respected doctors and our colleagues. At the outset, I, Devkant, on behalf of Mankind Pharma Limited, welcome you all for another show that is the Indian Diabetes News Nucleus. And I welcome our both the esteemed guests, Dr. Sanjay Badada sir and Dr. Kovil sir. Welcome you, sir. And I would request Dr. Kovil sir to start with the further proceedings.
Thank you so much, Devkant. And all of you listening in, welcome to the 15th edition of Diabetes News Nucleus. Diabetes News Nucleus has been an endeavor of IJCP and it has been very well supported by Mankind Pharma. And our whole aim, vision, mission, and Diabetes News Nucleus for the last 15 months has been to get you the best in the metabolic space and help you enrich your work, your practice. What we do is that we go through whatever has been the latest data in the last 1 month, we curate that and we get it back to you. So let's have the headlines for this month. बुलाते हैं पूरा
सर आप म्यूट हो. Can you just unmute yourself, Dr. Rajiv?
I'm sorry that technological glitches are the norm today. So I'm going to restart everything. Welcome to the 15th edition of Diabetes News Nucleus. This has been an endeavor of IJCP and it has been very aptly supported by Mankind Pharma. And our mission and vision for Diabetes News Nucleus has been to get the best in the metabolic space to all of you. What we do is we curate a lot of data in the past 1 month which has come in and then get it to you on this digital medium, and we call an expert of the month and we discuss one defect that you normally see in the metabolic space. So let's have the headlines for this particular month. Am I in the show? I can't.
Yes, sir. You can start. Sir, you can start. You are live already.
I'm not getting Wi-Fi.
You're in the show.
Can anyone hear me? Banu,
Yes, sir. We can hear you, sir.
Manmeet? You can
Yes,
hear
yes.
me?
You
Okay,
we
okay,
can.
okay.
Yeah.
Because I was not sure whether I'm logged out or not. So let's have the headlines for the day. I hope I'm audible to all of you. The headlines. Sorry, we are facing some technical glitches this time. I apologize for that. The headlines for this particular month. A very interesting article came online in the Journal of American Heart Association, and it actually looked at what we always knew was there, but we needed evidence to support it. That whether anxiety can be linked to risk factors for cardiovascular disease and diabetes, and this was longitudinally done over a period of 40 years to just realize that anxiety in men is tied to risk factors for cardiovascular disease, and this was done by certain questionnaires and certain scores, cardiometabolic risk scores, which told us that there is a slight gender differences, and the risk goes up till the age of 65, and there's a slower increase after the age of 65. So probably the main years of, or the productive years of life in a man is driven by anxiety, and probably that could be linked to cardiovascular risk factors. Again, we all know that gestational diabetes is like a stress test for future type 2 diabetes. It unmasks people who are at risk for type 2 diabetes in future. But a lot of data in the last 1 year has suggested that gestational diabetes has also been tied to long-term cardiovascular risk. Cardia, which came in just probably 3 months back, suggested that women who had gestational diabetes are at very high risk for cardiovascular event. And this particular data, again, which comes from the UK Biobank and has studied more than 500,000 women who had got gestational diabetes during pregnancy, speaks about a very high risk for cardiovascular disease in their middle age life. Another thing is that we always know that there is a lot of metabolic abnormalities, and that drives type 2 diabetes, especially metabolic abnormalities related to obesity. But obesity and type 1 diabetes is not so as a linear association. Almost 60% of patients with type 2 diabetes have obesity. But what has been seen that the prevalence of obesity has been increasing in the last few years, even in type 1 diabetes. So it has increased from 32% in 2004 to almost 37% in 2018. And this has been also linked to a reduction in their EGFR. So obesity, chronic kidney disease, type 1 diabetes is also becoming a triad, as one could say. Another thing is about we normally face this in clinical practice, that some of our patients who are on GLP-1 RAs somehow do not respond to therapy, and some do respond to therapy. A newer data which comes out and what recently got published in the in a journal of psychoneuroendocrinology talks about how emotional eating may override the GLP-1 agonist against weight loss. So a lot of people find comfort in food, and we all know that people who have some amount of depression find luxury in eating food. So emotional eating is a tendency to eat in response to negative emotions to relieve stress, often while disregarding internal satiety signals. And this crossover study with liraglutide, where patients were on 12 weeks on liraglutide and switched over without liraglutide and put on glargine, clearly shows using functional MRI at 10 days and 12 weeks of treatment shows that emotional eating may override the neurological benefit or the satiety suppression that GLP-1 agonists are very well known to have, and that could be the reason that some of our patients who are on GLP-1 analogs do not get the same kind of benefit. Another very interesting data which comes from Denmark and got recently published online in the Lancet looks at whether we are missing a lot of diagnosis of type 2 diabetes by using HbA1c as a surrogate marker of diabetes. Till now, we know that HbA1c is a surrogate marker of control of diabetes, but in 2012, the WHO and the ADA and the bigger bodies like the EASD also welcomed the move that to use HbA1c as a diagnostic marker for type 2 diabetes. Following which, in this particular study in the Lancet, they say that the diagnosis of type 2 diabetes has gone down, probably because we have been using HbA1c and probably are fasting PP or a fasting and an oral glucose tolerance test may be a much better sensitive marker for picking up diabetes rather than an HbA1c. Well, time will tell. There are two schools of thought. Some believe that this is an interesting paper, but bit hard to believe that the change could have so much of impact in public health also. Another very interesting article which came out was in the Lancet Gastroenterology and Hepatology, where investigators did a systematic review of RCTs and looked at anti-hyperglycemic drugs and their effect on NAFLD. We all know that NAFLD is the harbinger of type 2 diabetes. It is the kind of we can say the kingpin in all these blunders which cause type 2 diabetes. And if we have a good functioning liver, one may not develop diabetes is what one would look at. And three different classes of anti-hyperglycemic drugs have been used in NAFLD. PPAR gamma agonists like Pioglitazone, GLP-1RA, all of them I would say we have good data from liraglutide, we have good data from dulaglutide, emerging data from semaglutide, some futuristic data with tirzepatide. So there is some data from the incretin based therapy, and we also have some data from SGLT2 inhibitors. And this systematic review looked at 25 active or placebo controlled trials, and what they showed is that pioglitazone and GLP-1 RA, especially liraglutide and semaglutide, improved individual histological features of NASH, and again they also resolved NASH without worsening fibrosis as compared to an SGLT2 inhibitors, especially EMPA and DAPA, which only reduce the fat content. So again we need a much bigger phase 3 trials, and today a lot of studies especially looking at toll-like receptors and which may target toll-like receptors, because we all are on the same page when we say that NAFLD is also a sort of an inflammatory issue, and if we can reduce fibrosis, prevent the progression of fibrosis and reverse fibrosis with any kind of therapy, we know that almost 60 to 70% of patients with type 2 diabetes and almost 20 to 25% of the general population has NAFLD, and it continues to remain the highest cause of cirrhosis globally. So it's a huge public health problem, and if we can have good, resourceful, evidence-based medicines for treating NAFLD, it would be a huge boon for all of us. Now let's move to the topic of the month. Thank you. The topic of the month is diabetes, bone fragility, and fractures. And let me have the privilege of introducing our special guest. Our guest for today is Dr. Sanjay Kumar Badada. He's a professor and head of endocrine at the PGI MER Chandigarh. He's the founder and current chairman of the Chandigarh chapter of RSSDI. He also is the president-elect of the Endocrine Society of India. Welcome, Dr. Sanjay Badada. Welcome to Diabetes News Nucleus, and we are thrilled to have you here to discuss a problem which everyone believes they are a master at, and nobody actually knows how to treat it. So first, let me start with is diabetes and bone turnover and osteoporosis, is there a link to it? let's start with that. What do you think? Is there a link between metabolism, glucose control, and bone mineral metabolism?
Yeah. So, thank you, Dr. Kovil, and thank you, IJCP, for this opportunity. So, yes, there is a connection between type 2 diabetes and the bone health, and this connection is at various levels, which is at the macrostructure, at the microstructure, at the histopathological level. So, if we say in other words, like we generally in diabetes talk, there is three microvascular complications are there. That is retinopathy, neuropathy, and nephropathy. And the reason for defining these microvascular complications are based on the vessel size. So vascular size less than 5 micron is actually defined as microvascular complication. And it has been shown that in bones also they have the microcirculation that is less than 5 micrometer. So meaning by that is also a kind of microvascular complication in addition to these three well-known microvascular complications. Yes, Dr. Kovil?
I think we have technology which is working, or Wi-Fi working as a villain today, Dr. Badara. Please continue.
Yeah. So then the relation is various epidemiological studies have shown very clearly that fragility fractures are much more common in diabetes as compared to non-diabetic individuals. And further, in type 1 diabetes, the fracture is approximately 5 times more frequent as compared to their non-type 1 diabetic counterpart, age and gender match. While in case of type 2 diabetes, again approximately 2.5 times more fractures in type 2 diabetes individuals compared to the age and gender matched non-diabetic individuals. So it is very clearly documented in various studies, epidemiological studies on meta-analysis that patients with diabetes are at more risk for fragility fractures. Now you ask the question about say metabolic effects. So basically, bone is a very dynamic tissue. Every year, our 10% of skeleton is renewed, new skeleton is formed. Though in general, we think that bone is an inert tissue and there is not much metabolism. No, it is not. Actually, approximately 10% of the skeleton is renewed every year. And because of hyperglycemia, because of deposition of advanced glycation end product in the bone, like in other body tissues and body organs, that will actually inhibit the metabolism or the renewal of the bone, and that causes a dynamic state of the bone in type 2 diabetes as compared to a non-diabetic individual.
Thank you so much for that answer. So is there any screening guidelines one should have for people with type 2 and type 1 diabetes as regards to that bone mineral?
Okay, so right now, regarding the cutoff to screen for osteoporosis in diabetes is not yet defined. That do we screen little early as compared to the non-diabetic individuals? It is not mentioned, but it is known that once the duration of diabetes is more than 5 years, then patients of type 2 diabetes can be screened for the uh, bone mineral density estimation. Now, the another question is that because various studies have shown that individuals with type 2 diabetes are having higher bone mineral density as compared to the non-diabetic individuals. But in our own study, which is a hospital-based study, RSSDI supported study, we found that BMD is not high in type 2 diabetes individuals in India. And few more studies are those are supporting that BMD is not high. But certain Western studies are supporting that BMD is high in type 2 diabetes. Now the question comes is that if you are getting a DEXA scan, how to interpret it? Is there any change in the interpretation of the DEXA
Absolutely.
scan with relation to type 2 diabetes? So now the few papers are there, and the one of the standard textbook of endocrinology, that is Williams textbook of endocrinology, that mentions that in general population, if we diagnose osteoporosis by T score of minus 2.5 or less, in diabetes, it should be diagnosed when T score is minus 2 instead of minus 2.5. So that is one of
Okay.
the correction they advise in view
Mm-hmm.
of increased risk of fragility fracture in patients with diabetes.
Okay.
Another suggestion given by various societies, like that FRAX, that is fracture risk assessment tool, that is used to predict the future fragility fracture at the hip or at other sites. So they mention that generally the diabetes is not in that questionnaire, but they say you can take the rheumatoid arthritis as patient is not having rheumatoid arthritis but having a diabetes, and you
Mm-hmm.
can calculate the FRAX score
Okay.
to predict the fragility fracture. Meaning by that, they advise these two changes. One is the change in the T score from minus 2.5 to 2, and the second is the tick in that FRAX questionnaire. Instead of rheumatoid arthritis, if it is not there, still you have to tick that, so that will calculate the risk less the patient is having the rheumatoid arthritis or patient is having the diabetes. Yeah. So this is related to the screening. Now, if you want to know what is the treatment plan, I can talk to you regarding the treatment plan. Or if you have any other question, please ask me.
Yeah, Dr. Barra, please continue. There is.
Okay. So now the once the screening is done, and as I mentioned, if the patient is qualifying for the diagnosis of osteoporosis, then we can plan the treatment in patients of diabetes. Of course, the first and most important thing is the good glycemic control, because that is going to help as much as possible. And the target is same, that is the 7 HbA1c or the 6.5. After that, we know that for any disease, treatment in medicine is the non-pharmacological management and followed by the pharmacological management. So in the non-pharmacological management, two, three things are very, very important. One is that adequate nutrition, that says the calcium in the diet. So that is recommended calcium is 1000 milligram per day. So when an individual is able to take 1000 milligram of calcium per day by diet, it is fine. No need of supplementation of the calcium. But in patients of diabetes, it is difficult to get 1000 milligram of 1000 milligram calcium per day by diet. So in that case, we can supplement with the at least 500 milligram calcium tablet per day, and 500 can be obtained from the dietary
Right.
prescription or from the diet. Now, coming to the next one is the vitamin D, and we know that vitamin D is very important, and the deficiency is more common, and the few people are more prone for the vitamin D deficiency. One of the condition is the diabetes and obesity, and we know that diabetes and obesity often comes together or exist together. So that's why the type 2 diabetes is a state of, say, vitamin D deficiency. So that's why these individuals require the adequate amount of the vitamin D supplementation, and the recommended vitamin D intake per day for an individual with type 2 diabetes is 1000 to 2000 international units per day, or a 60,000 tablet or the sachet once in fortnight to once in a month. And the target vitamin D level is 30 nanogram per ml for diabetes, like in any other non-diabetic individuals. So basically, the calcium and vitamin D supplementation is the same in both the condition with and without diabetes, but Diabetes and obese individuals are more risk to having the vitamin D deficiency, so we have to take care that we should adequately replenish the vitamin D uh, level by supplementation.
Uh, uh,
Now, yeah,
Dr. Barada, just at this level, I like to ask you two questions.
yes,
One
yeah,
is that apart from DEXA, is there any cheaper method of diagnosing osteoporosis or bone mineral density? Because it may not be possible to do that, because of the cost factor.
okay. I think Dr. Coyle, very nice question, but currently the DEXA scan is the gold standard test to diagnose the osteoporosis. Other modalities are available, like there is a ultrasound is also used for that, or maybe X-ray can also be used for that. But I think these are not very what you call standard one, and not
Reliable
very
and
reliable. Reproducibility is not good. So the currently DEXA is
true,
the method of choice, and
gold
I
standard.
believe it is maybe cost is there, of course, but that's the ideal one.
And as far as vitamin D, for all the viewers who are listening in,
Yeah.
people keep on repeating vitamin D levels after you have started supplementing. So how long is this supplementation? Is this 500 and fortnightly vitamin D 60,000 lifelong? Do you need to keep checking for the values? What is your recommendation?
Yeah. So basically, I believe in in the cost effective way. There is no need to repeat the vitamin D level. Once vitamin D level is done and the patient is deficient, he should be supplemented with the vitamin D. And vitamin D in general requires the lifelong supplementation, because it has been documented in multiple Indian studies that the vitamin D deficiency is rampant in India, though the sunlight is very good. Still, the vitamin D deficiency is very rampant. So, instead of checking vitamin D to look for the what is the level, it is costing maybe 1,000 rupees, or at least 500 to 1,000 rupees, and by that you can
Yes.
purchase 1 year vitamin D supplementation. So I suggest there is no need to repeat time and again vitamin D levels. Just once it is fine, and otherwise as long as you are taking vitamin D it will work, that is for sure. If the person is not taking vitamin D, I am sure that will not work. So that is the important thing.
Fantastic. Now, then you can go ahead with the therapy, what we were discussing.
Yeah. So before going to the pharmacological management, I want to tell very important thing, that is the fall prevention. Fall prevention, because the person will develop a fracture, he or she, when she falls. Actually, that is a very important. And the patients with type 2 diabetes are predisposed for the falls, because of n number of reasons. You can see the patient is having the retinopathy and there's some vision problem, or patient is having cataract or there's some vision problem, they are more at risk for the fall. Number two, patient is having the peripheral neuropathy, they are more risk for the fall because they lost their proprioception sensation. Patient is having autonomic neuropathy, they are prone for the postural fall, giddiness, and again predisposes for the fall. Then patients with type 2 diabetes per se, they may have the muscle weakness that will also predispose for the fall. Then patients on various medications, and some of the medications having the first dose hypotension, like ARBs, ACs inhibitors, they can further predispose us for the fall because of the postural hypotension. And uh, other multiple reasons like the diabetic foot involvement, some imbalance, all these things are predisposed to the fall. So patients with type 2 diabetes and type 1 diabetes are uh, at very high risk for the fall, and the fall is an important reason for the fracture. Now the question comes is how we can prevent fall. So, to prevent fall, I think it has been shown in some of Indian studies and our own study that the most common site of fall is home itself, house itself. And in house also, the bedroom and the bathrooms are two sides or the places where the patients are maximum uh, chances of fall are there. So what we can do, this is a very brief information, but I believe it is very, very important, not only for the
It's very
patients, but
relevant also. Yes.
yes, and for all doctors also, because some we stay with our parents, our fathers, and uh, they are also having the uh, risk of fall. So I'll start with the bathroom, that is most common site where the fall happens. So that first and most important is that when the person enters in the bathroom, light should be on. So for that, light switch should be outside the bathroom, not inside the bathroom. Number two.
Right.
Number two, light should be adequate in the bathroom. Number three, when you come out of the bathroom after taking your bath, please wipe the bathroom floor very properly. Then there should not be any spillage of shampoo, soap, etc. Then, and then the important thing is that while taking bath, the things should be arranged in such a way that the person who is taking, elderly person taking bath, should not have any problem in that. Otherwise, while fetching the things from above or from the distance place, they may likely to fall. After taking the bath, it is a common practice to wear clothes in the bathroom itself. That is a very, very important thing, because while you are wearing your pajama or your pant in the bathroom, you are likely to have imbalance and you are likely to have the fall. So what we should do is that educate our elderly, those are at home, never wear your complete cloth in the bathroom. Just have some towel and come out of the bathroom, sit comfortably on the bed or the chair, and then sit these things. Because I have seen many persons, they are trying to change their clothes and wearing in the bathroom and having imbalance and they are falling. So these are the few things for the bathroom. Then the bedroom is very important. Luckily now the telephone line is not there. Most of the people having the mobile phones. So otherwise, that any clutter in the bedroom from entering of the door to the bed, that can also predispose an individuals for the fall. So these are the some of the things can be taken care to prevent the fall. So that is there.
Fantastic. Those are very, very good practical tips, and
Yeah.
prevention of fall will go in a lot, because we know that when there is a fall, the patient is usually bedridden, and then all the catastrophe would start. Fantastic, Dr.
Yeah.
Raghunath. So, yeah, please
So
go ahead.
what
Please
I
go ahead.
say that hip fracture is not less than a malignancy.
Yes.
Okay, and to popularize the term, now we say that is a bone attack, like heart attack, like brain attack, that is a bone attack. If there is hip fracture, that can be called a bone attack. And the hip fracture outcome is really very, very poor. And we have
Absolutely.
seen that within 1 year, within 1 year, the approximately 20% of people are dying because of the hip fracture, and over the end of 5 years 50% people are dying because of the hip fracture related complications. And the morbidity is immense morbidity is there with the hip fracture. So the prevention is the best, and for the prevention, of course,
Is
calcium.
this is this
Yeah.
is this globally, this kind of 20% at the end of 1 year, and it is as worse as any cancer per se?
Yes.
Is it globally there, this kind of?
Yes, yes, it is globally there, and it is more worse in India. And unfortunately, in India, the fracture age is earlier, almost a decade, as compared to the Western population. It is
Okay.
similar, like we have early vitamin D, early diabetes, we have early osteoporosis, we have early hip fracture. So everything is 1 decade earlier as compared to the Western counterpart.
So hip fracture is very very similar to the diabetic foot amputation in terms of its.
You can take the similar analogy. Yes, you can take similar analogy like diabetic foot. If one side
Uh,
amputation is there, in another 5 years,
so
another
hip
side amputation.
fracture, 5 year survival is almost very similar to a diabetic foot amputation of the leg,
Yes,
Dr.
correct.
Parad,
Right.
isn't it?
Yes, yes. Yeah. So now coming to the treatment of osteoporosis with type 2 diabetes is this currently the treatment is not different. Like in any osteoporosis, treatment of osteoporosis with diabetes is the same. So the first line of drug you can use is that uh, bisphosphonates, and the preferred one is the, in my practice or in our institute, what we do is that we prescribe the zoledronic acid once in a year, and we follow these patients with the bone markers and the DEXA scan. If the DEXA scan is in the normal references after the injection, will not give the next injection, or if it is not in the reference range, then we repeat the injection every yearly for 3 to 4 years. But if we talk about uh, best ideal drug according to the scientific evidences, in that case maybe teriparatide is the preferred drug, because teriparatide is anabolic agent as compared to the bisphosphonate, which is a anti catabolic. Basically it inhibits the bond resorption, while the teriparatide, which is an anabolic agent, and it will form the new bond. And we know that diabetes is a state of adynamic bond disease. So if we treat these patients with the teriparatide, the outcome will be better as compared to we treat these patients with the bisphosphonate, that is basically a anti-resorptive treatment. Now, coming to the question is how long to treat these patients. So, like a similar analogy to type 2 diabetes, you need a treatment lifelong in type 2 diabetes. Here in osteoporosis, also the treatment is the lifelong. So, you can argue that lifelong meaning by that, if a person starts the treatment at 65 years, if he's of 70 years or 80 years, should he continue to take treatment? The answer is yes, he should continue to take treatment. But of course, the frequent monitoring is required with the DEXA scan for the bone mineral density, as well as for the bone turnover markers to decide the when to repeat the next dose or to hold on the next dose for some more time. So the bisphosphonates and teriparatide are very well-known treatment, but another new drug which came in India also, that is called denosumab, and the denosumab is having added advantage over bisphosphonates in patients of type 2 diabetes, because some studies shown that denosumab is also helpful to improve the uh, glycemic control, and we know that poor glycemic control is one of the uh, important reason uh, for the osteoporosis or the poor bone health in type 2 diabetes. So the denosumab is having an advantage of improves glycemic control. So you can say that denosumab can be another choice. And we know that denosumab is given once in 6 months. Once in 6 months, and that is a subcutaneous injection. And so far, more than 10 years safety data is available, so you can continue to use the denosumab for the 10 years. So basically you can use all these three drugs, anyone, that is bisphosphonates, that is denosumab. These two are actually anti-resorptive agents, and the teriparatide, that is a anabolic agent, or the recombinant PTH. The recombinant PTH is prescribed just for the 2 years only, not more than 2 years. So after the 2 years completion of the recombinant PTH or the teriparatide, patient should be given any of the anti-resorptive agent, that is either denosumab or the bisphosphonates. And the safety data for the denosumab and bisphosphonate is available for more than 10 years. And the various studies have shown that they not only prevent the spine fracture, but they also prevent the hip fracture and can improve the longevity. Dr. Rajiv. So, Devkant, you have any more question for me?
Sir, just wait. The Doctor Ravi just got disconnected.
Yeah, no problem. So, you have any more question in pipeline? I can answer, but otherwise, this is a standard plan for the management of osteoporosis in type 2 diabetes, the screening tools, the non-pharmacological management that include calcium, vitamin D, fall prevention, and in the pharmacological treatment that includes the bisphosphonate, denosumab, and recombinant PTH. And the treatment is usually lifelong, and the monitoring is by the DEXA scan for the bone mineral density and bone turnover markers like the P1NP and CTX. Okay, we can have questions from the audience or we can have questions from your moderators. Yes, Vanu.
So I'm just checking the questions part.
Okay, good.
I'm sorry, my internet is giving me issues today for reasons unknown to me. I'm so sorry, I had to restart my whole laptop. So, coming back, I missed the last part of yours and about bisphosphonates diabetes.
Yes, Dr. Rajiv, I think,
Can you hear me, Dr. Badana?
yeah, now I can hear you. Can repeat your question.
Can you hear me?
Yes, yes, yes.
Okay, there's some instability in my connection
No
today.
problem. So there is a
Don't know
question in
what.
chat box when one should start bisphosphonate diabetic patient, how
Yes.
long to be given? So I
How
think I
long to
given
be continued? Yeah.
yeah. So I given the answer that that can be given for 3 to 5 years, and if the BMD is the normal reference range, they can stop the bisphosphonates. And though of course there is now the bisphosphonates safety data for more than 10 years, so there should not be an issue. They can take for at least 10 years if it is required. But 3 to 5 years and then can give a drug holiday. They can stop for few months or few years. Yeah.
Okay. So there is one more question. So what is the normal HbA1c in pregnancy and how much sugar is desirable after taking meals in diabetes in pregnancy?
Very not a very nice question, but anyway, what is the normal HbA1c in pregnancy? So it is not yet mentioned because in pregnancy is not monitored by the HbA1c because of obvious reasons. And how much sugar is desirable after taking meal in diabetes? I believe the person wanted to know what is the blood glucose level. So the blood glucose level after meal is less than 120 milligram per deciliter. Yeah.
So next question is, are pioglitazone safe in elderly patient?
I think is a very interesting question. And when especially you are thinking about bone
Doctor,
disease and diabetes, then pioglitazone should be avoided. And in our practice, we are stopping pioglitazone in elderly persons because of there is associated risk of fracture with the pioglitazone because pioglitazone causes acting on the bone marrow and then they are actually shifting the mesenchymal stem cell towards the adipocyte instead of the osteoblast lineage. So that's why the pioglitazone should be stopped in elderly person, especially if they are at risk for the diabetes.
Okay. So
Is
I guess
BMD
this,
test
yeah,
yeah?
sorry, sir.
Is BMD test recommended in all diabetics? So all diabetic, no. I must say that if the duration of diabetes is more than 5 years, there is a recommendation for the BMD testing, not for all diabetic. Meaning whether a person is of 30 years old and is known to have diabetes, he is not requiring a BMD testing. Okay, next question. SGLT2 inhibitors and calcium relationship in cases of osteoporosis and osteoarthritis. Throw some light on it. Okay, so basically SGLT2 inhibitor is good for pump, pipe and filter. That is one of the nice title given for the SGLT2 inhibitor. So it is working good for the vessels, for the heart as well as for the kidney. But regarding bone health and SGLT2 inhibitors, currently the data is not very clear. In one of the study where canagliflozin was used and shown that there is increased risk of the amputation in the diabetic foot, but it is not shown to be proven with other SGLT2 inhibitors. So currently the condition is say what you can say the concept or the
With other SGLT2 inhibitors. So currently the condition
is not clear that SGLT2 inhibitor is uh, used or not used. So the data is still not out. So I suggest if person is having osteoporosis, they may be avoided SGLT2 inhibitors.
doctor, but I'm keeping my
No
video
problem. I
off,
think you
so
can
probably we can
switch
use
off
that's the
your
Wi-Fi.
video so it will work.
Yeah,
I think.
about bisphosphonates in diabetic patients, how often a BMD?
How often?
That's what I've done, So bisphosphonates when we use,
Yeah.
do you think an annual BMD needs to be done?
Yeah, it is similar. Yeah, it is in the similar fashion as in the non-diabetic individual with osteoporosis. But for screening may not be every year. If there is established osteoporosis is there and patient is on treatment, then yearly screening is required. Otherwise, like in non osteoporotic individuals, the screening is maybe 3 to 5 yearly only, not every yearly. So another question in chat box is that is tight control of blood glucose level having lesser incidence of osteoporosis and vice versa? So yes, the answer is yes. The good glycemic control will be preventing the bones, preventing osteoporosis in type 2 diabetes individuals, because hyperglycemia is one of the mechanism responsible for the osteoporosis. But the one thing is that if the very tight glycemic control sometimes can cause hypoglycemia, that can predispose us for the fall, and that can be a problem with the fractures. Yeah. Uh, Devkant or Banu, any more question in chat box?
No, sir. That's all from yeah, sir, from the chat box, sir.
So one question is that I can see diabetic patients are mostly obese. That's correct. Overweight. That's correct. Can calcium supplements raise weight? No. Calcium supplementation will not increase the weight. Rather, if you try to take calcium from diet which is required, that can sometimes can cause weight gain. Which calcium advice in older people? I think there is as such no specific calcium. Any calcium can be taken, but for elderly people, calcium carbonate should be avoided, because calcium carbonate require the acidic medium for the absorption of the calcium. So that's why in the elderly people, calcium carbonate may be avoided and can use the calcium citrate maleate. So another question is how to prevent muscle loss. A very interesting question. So the best way to prevent muscle loss is that good glycemic control and good physical activity and adequate protein intake. These are the clues to prevent the muscle loss. Otherwise, after 40 years of age, um, every year there is 1 to 2% of muscle loss is there. Next question, DM with osteoarthritis. What is the line of screening and management? Well, I am not an expert in osteoarthritis, so I don't think I am a right person to answer this question, but there is no such guideline I am aware of any that osteoarthritis. But if the patient is having the features suggestive of knee pain and it is persisting, then they can obviously get their uh, knee x-ray to look for if there is any osteoarthritis is there or not.
I've tried to reset. Can I be heard again? Uh, Dr. Barada, the role of teriparatide in osteoporosis, is there?
Yeah,
How
so I
long do we
mentioned
use it?
also that teriparatide is a good choice because it is an anabolic agent. So teriparatide is a good choice for the treatment of osteoporosis in type 2 diabetes.
Mm-hmm. Let me see if there are any further questions. So what we heard from the expert today is that the cutoffs for osteoporosis are different in diabetes. He says a T-score of minus 2.0 to be taken. In the FRAT scoring, you should look at considering the tick of rheumatoid arthritis. That is important. We need to understand that falls need to be prevented in people in the elderly, and he elucidated fantastically on how that kind of patient education can help, especially in the Indian condition where his data also suggests that falls occur in bedroom or bathroom. Illumination and some amount of preventing falls, that's important. We looked at how a 500 milligram calcium supplement along with probably 1500 to 2000 international units of vitamin D supplement daily could help a very very long way in strengthening our bones. And this, and along with bisphosphonates and so many other therapies which Dr. Badada spoke about. I think, Dr. Badada, unfortunately, my connection is coming and going, and it's rather very distressing and very irritating. But I'm extremely sorry for this, beyond my
No problem.
control, beyond my
No
control. But
problem.
I believe a lot of people who have viewed in, and we have a lot of good viewership. They have gained a lot from today, because osteoporosis is a word which everybody uses, right from the lay people also, and somehow nobody knows how to diagnose, for how long to use treatment, and how to prevent falls. And as you said, that the mortality, 5-year mortality following a hip fracture, is almost equivalent to a cancer and a diabetic foot. So that kind of importance needs to be given to prevention of fractures in the elderlies, and that can go a very long way in preventing the morbidity and eventual mortality in that population. So at the end of the session, I would like to really thank you for sparing this time, and a lot of practical tips for all the people who have been viewing in and watching you over the last 57 minutes, with me coming and going. But I believe it was a wonderful, simplified way of explaining osteoporosis, because majority of people listening in are physicians, and they would like to enrich their practice by actually getting it from an expert who actually deals with these kind of problems on a day-to-day basis. So thank you so much, Dr. Badada, for joining us. Thank you very, very much. And to all the viewers today, I hope you all have had enrichment of knowledge, especially in the field of bone and mineral metabolism. And if you have any queries, you can write to us, and we could forward it to Dr. Badada. And if there are any unanswered questions, the Mankind team and the IJCP team will be more than happy answering any of those questions. And we will be back again next month with a fresh, newer, whatever data comes in. We don't know, we don't have the crystal ball, so we don't know what we get. But we will have another expert from the metabolic space, again enlightening us about the particular field that he has his own interest in. And we will see you all next month. Thank you all so much. Thank you, Dr. Barada. Thank you for being here with us. Thank you so much. I hand it back.
Thank you, Dr. Rajiv. Just want to say I am coming with a book that is on the osteoporosis. So that is in Hindi. That
Okay.
can be useful for the our viewers if anybody is interested.
Fair.
It is in Hindi and showing all pictures. How should be your bathroom? How should be your bedroom?
Fantastic.
And all this the real pictures.
Fantastic.
And that will be
That
very useful. So
I
IJCP
think that would be a huge value addition.
Yes.
Thank you
Thank
so
you.
much. I hand
Thank
it
you very
back to
much,
the
IJCP.
Mankind team. Thank you so much. Thank you, Dr. Barada.
Thanks.
Yeah, thank you so much, Rajiv sir and Sanjay sir, for this great discussion. And I hope that our audience would have get some value addition in their experience as well. So we'll be coming back in the next month with the latest updates in the diabetes as a segment. So till then, enjoy your Sunday evening. Thank you so much, everyone, for
Thank you
joining
so
us
Thank
much.
today.
you. Bye bye.
Thank you.
Bye
Good
bye.
night. Thank you. Good night.